Tetralogy of Fallot is the most common cyanotic congenital heart disease, characterized by a specific constellation of anatomical findings. For pediatricians, a good understanding of both clinical presentation and echocardiographic details is essential for timely referral and perioperative management. Tetralogy of Fallot is fundamentally a disease of anterior malalignment of cornel or infundibular septum. This single embryological error leads to 4 classic features: large unrestrictive subaortic ventricular septal defect, multi-level right ventricular outflow tract obstruction, which could be infundibular, annular or valvular, overriding aorta, VSD receiving blood from both ventricles. As a secondary response to the high pressure environment of the right ventricle, there is right ventricular hypertrophy. Clinical presentation depends entirely on the degree of right ventricular outflow tract obstruction. If the obstruction is mild, the shunt may be left to right, like a simple ventricular septal defect, and the infant appears well oxygenated. However, as the infundibular muscle hypertrophies over the first weeks of life, they often transition to cyanosis. The murmur you hear is not that of the VSD, which is too large to be noisy. It is the crescendo-decrescendo murmur of pulmonary stenosis. A softer murmur during a spell actually indicates worsening obstruction. TED spells or hypercyanotic episodes are medical emergencies caused by a sudden increase in right ventricular outflow tract obstruction or a drop in systemic vascular resistance. Immediate knee chest position increases systemic vascular resistance and reduces right to left shunting. Calm the child. Agitation increases catecholamines, which worsens infundibular spasm. Oxygen, morphine to suppress the respiratory drive or agitation, and intravenous fluids are useful. Beta blockers are also used in the management of TED spells. Echo remains the primary tool for surgical planning. Beyond the core 4, specialists look for specific surgical spoilers. Pulmonary annular SED score. A SED score less than -2 to -4 often necessitates transannular patch rather than a valve sparing repair. That is, having a chance for higher rates of pulmonary regurgitation. In about 5% of cases, left anterior descending coronary artery arises from the right coronary artery and crosses the right ventricular outflow tract. This prevents the surgeon from making a standard incision in that area. 25% of tetralogy patients have a right aortic arch, which is vital information if a palliative shunt like a Blalock-Thomas Taussig shunt is needed. Branch pulmonary arteries must be assessed for stenosis or hypoplasia, measured via the Magoon ratio or Nakata index. A SED score or Z-score tells you how many standard deviations a measurement is from the mean of a healthy population. SED score is equal to 0. The measurement is exactly at the population mean. Z-score +2 or -2. The measurement is roughly at 97th or 3rd percentile. In most pediatric echo labs, a Z-score between -2 and +2 is considered the normal range. The Magoon ratio is a simple linear measurement. It compares the size of branch pulmonary arteries to the size of the descending aorta. Magoon ratio is equal to sum of diameters of right and left pulmonary arteries divided by diameter of descending aorta at the level of diaphragm. Normal value is more than or equal to 2.0. Adequate repair is possible if Magoon ratio is more than 1.2. Some centers use 1.5 as safer cutoff. And if it is less than 0.8, usually indicates that a shunt, like a BTT shunt, is needed first to help the pulmonary artery grow before a full repair. The Nakata index is a more precise area-based measurement. It calculates the cross-sectional area of the pulmonary arteries and indexes it to the child's body surface area. Nakata index is equal to area of right pulmonary artery plus area of left pulmonary artery, both in square millimeters, whole divided by body surface area in square meters. Normal range is more than 330 square millimeters per square meter body surface area. For adequate repair, you need more than 150 square millimeters per square meter body surface area. If it is less than 100 square millimeters per square meter body surface area, it often predicts poor outcomes or the need for a staged approach. Post-repair monitoring is also highly important. Goal of surgery is just excellent palliation. It often leaves the patient with pulmonary regurgitation, and chronic pulmonary regurgitation leads to progressive right ventricular dilatation. Red flag signs on echo may be paradoxical septal motion, tricuspid regurgitation signaling right ventricular failure, and a low tricuspid annular plane systolic excursion that indicates poor right ventricular function. All this can also lead on to arrhythmias. Sudden cardiac death can occur in post-repair tetralogy of Fallot and needs arrhythmia monitoring as well. Here are the differential diagnoses. If a neonate presents with cyanosis and a boot-shaped heart on X-ray, consider tetralogy of Fallot with pulmonary atresia, which is more severe and ductal dependent for any lung flow. Double outlet right ventricle if the aorta is more than 50% committed to the right ventricle. Tricuspid atresia often presents with similar quiet lung field on X-ray. ECG may show left ventricular forces in tricuspid atresia.